And thank you, Rich, for the invitation. Ayo, and everyone, all the collaborators, nice to see you. When I look at the aims of the BIPS Institute, say that you want to prevent NCDs, but not just to focus on individual behavior, but also the environment that impacts the behaviors. All of that fits very well into the UN's mission, vision, and our framework of NCD prevention is fully aligned. So I think that's the beauty of coming to institution to see that we are very well aligned, and we are a WHO collaborating center. So I will take you through some of the our recent discussions on this topic. It's very important that we are meeting today because we are just after a UN high-level meeting last September where heads of states met in New York. And for the first time, this is not WHO, this is the heads of state. They have met before. They have discussed NCDs before, but this is the first time they agreed on some targets, some numbers, right? Normally, heads of states don't like to commit to numbers. They know it's problematic. So they leave it to health ministers and they only talk about policy. But this time, countries agreed on 3 numbers. By 2030, 150 million fewer tobacco users, 150 million more people with hypertension under control, 150 million more people with access to mental health care. Okay, we started with about 10 and we left with these 3, as everybody could agree, as any other negotiation. But it's good to have something measurable. If you work on mental health, if you work on hypertension, tobacco, that means you are addressing a lot of underlying issues. You can't just get these 3 without addressing a lot of other factors. So this is good. Despite a lot of other misses, this is good. And then coming back to our European region, when we talk about 90% deaths of NCDs, and that we won't take action, some people say, oh, that's not a problem. That's a good thing, people dying from NCDs. We have solved all other problems. It's the old age, you have to die from something. So now we talk about avoidable deaths, not just the total number of deaths. Okay, how many deaths we could have avoided through treatment and through prevention, both together. And in Europe, we estimate about 1.8 million deaths are avoidable from NCDs. And these cost about 514 billion US dollars. So this is the economic cost and health cost from NCDs that we could avoid. I'll go into a little bit of this slide. It's a complicated slide, but I'll try to take 2 messages from this. As I mentioned, we can avoid deaths through treatment and through prevention. And these are 8 standardized death rates from the last available year that WHO has data for. So some countries 2022, some countries 2023. It takes a couple of years for countries to give us data. So you will see that on the treatment line, I have on this line, coming down means lower treatable mortality. They have brought it down. A lot of Western European countries are at the same level. That means this is how we interpret it. When we have evidence for treatment, they are adapted by countries quite at the same speed. And probably to the full potential feasible level, population get the benefit. But we have large variation in the preventable NCDs. And this arrow is supposed to be between Denmark and Sweden, 2 neighboring countries, with large variation from the reduction in preventable NCDs. And that's one way to present it is not all countries are using the evidence for prevention at the same level, or population don't get the benefit of prevention evidence at the same time, and there are more variation. So if you work, that's the area where we can save more lives, and that's where we have larger inequalities from the prevention side, more than the treatment side in similar countries. So it's important that we think about how we reduce this variation in prevention. Now, what have we achieved so far? So these global discussions on NCD prevention kind of started with 2011, first UN high-level meeting, setting targets, and we have been tracking progress so far. This dotted line is the SDG target to reduce 1/3 mortality by 2030. You will see until about 2020, WHO European region, we used to stand up and say, we are the only region on track to meet SDG target, right? Now we are also not anymore. We are off target now. We are not going to meet it. But that's not all bad news. last year I was on a public health leadership course, and one of the messages they said is, we are all only focusing on bad news and being unkind to ourselves. We never celebrate our achievement. So we modified the slide after that. See what we have achieved, right? We have saved 3.6 million deaths, we estimate, due to our actions between the last 10 years, and about 478 billion US dollars cost avoided, okay? So these are our achievement. Rather than business as usual, by changing the direction of the death rates, we have saved about 3.6 million. This is probability of dying between the birth, the 30 and 70 years. Okay, that's like premature deaths, probability of dying prematurely. And that means, yes, we have achieved something. Maybe we missed the target, not as much as we wanted, not as fast as we wanted, but there are achievements. So it's not that we are completely going in wrong direction. Now, this slide, I mentioned my previous slide, that since 2020, we see that we are not on track. It can be partly explained if you look at how countries are implementing NCD policies. So every year, no, every 3 years, WHO sent this questionnaire called Country Capacity Survey, asking countries about the policies they have implemented. And you can see since 2015, there was a steady increase in the implementation of WHO best buys. Now there's a stagnation after 2020, and that reflects in the reduction in the NCD deaths. So if you implement policies, we continue to reduce deaths. When you stop implementing policies, we get off track. When we take the foot off the gas, the trajectory changes. Very simple. Even when you dissect it by country level, you see the same pattern. Countries who implemented very strict alcohol control policies, such as Lithuania, within 2-3 years, sees the alcohol-related mortality down. And then the next government comes, lifts some of those policies, you see those death rates going up, and we see that. And at regional level, it reflected here. So, but we know what works. We have the WHO NCD best buys. This is the publication here. Maybe you are familiar, related to tobacco, nutrition, all these different NCD areas. But the implementation is low, as I mentioned. So we asked from countries why your ministers are not implementing this, because all the countries unanimously adopted this, right? There is no uncertainty. Everybody liked it. They all adopted it, but they're not implementing. The answer we hear is sometimes politicians feel that these policies will take 10 to 15 years to see results. But some of them are unpopular, or they feel political pressure from industry and others. When you are trying to put labels, when you are trying to increase taxes on unhealthy food, there's a political cost to that. But the results will come in 10, 15 years. Elections comes in 5 years, right? So they weigh these two things. And that's why we look at which interventions can give you measurable results in less than 5 years, what do you call WHO quick buys. So we have systematic reviews for about 25 interventions where we can confidently say, if you implement, if you enforce, and if you measure, you can show measurable results in less than 5 years for 25 interventions. But you need to pick the right indicator, right? So if you introduce smoke-free places, you might not be able to show lung cancer reduction, but you can show reductions in hospital admission with acute respiratory diseases, right? And related to that. So if with the right indicator, you can show results. And then when we are trying to implement these are cost-effective interventions, the next question comes on return on investment. Who gets the return? Health Minister says, all my projections shows health budget is going to increase in the next 10 years. I'm not going to tell the finance minister, if we implement this, I'm going to ask for less money next year for the health budget. That's not going to happen. So that's where, even within the health sector, we need to explain the return on investment, who gets the return. It may be a healthier workforce who give good productivity for different sectors, might not reflect in health expenditure reduction somewhere else in the society. So how do you explain cost effectiveness and return on investment to agree governments to invest these policies is our challenge. That's where the major barrier is, not on the effectiveness of the intervention. To get the cross-political agreement and politicians' agreement to implement them. So I will go into a couple of examples, not a lot, how to do that. One of the best buys is brief advice by the doctors about tobacco, about alcohol, or healthy diets or physical activity. A doctor or health professional telling people to do it, brief advice. There's on all areas, it comes as a good thing to do. But we know there are so many factors need to come out. So this is a manual and a report on the website. You can read more. We surveyed about 8,000 health professionals, and they all know this is good. They know about the evidence, but they don't do it. We ask why. Can I ask in this room, have you been to your doctor last year? Did the doctor initiate a discussion with you about your diet, physical activity, tobacco, alcohol without you asking? Did the doctor do? I have one. So this is right. We think 80% say no. So I think your room also reflects. But you might not be the general population sample in this room. But this is where it is, okay? 80% of our diseases are due to unhealthy diet, tobacco, alcohol, physical inactivity. When patients come in contact with our health system, if we don't take that opportunity to ask, initiate a dialogue, then where are our priorities? This is where the challenge is. That's why Ireland has introduced this every contact counts measurement. So even a mother comes to see the doctor for vaccination using that contact to ask these questions, right? But when we ask from doctors, why don't you do it? They say, if I start this dialogue with my patients about the alcohol, they might think I'm judgmental about them. I'm judging them by looking at them about the diet or alcohol. And they think this will harm the relationship between them and the patient. And when we ask patients, 80% of the patients say, I would really love my doctor to ask that question. They're always in a rush. I would want to have that conversation. So we have a clear gap. Evidence says one thing, evidence is clear. We have policies in all countries. This is a good thing to do, but it doesn't happen in the consultation room and between the doctor and the patient. And there are so many things that are affecting it, right? So if we just ask, do you have the policy? All the countries say we have the policy. And do you see the results? We don't see the results. Then people say, that's because this evidence is not good enough. We need to do more trials. That doesn't provide the answer. There are so many things which determine. It may be the health literacy of the patient and the doctor and the hospital who supports it. Everyone understanding this is a good thing to do. So no judgments. And another thing is about how the organization support it with training, how to initiate a conversation, how to maintain a conversation, having referral pathways. GP can only do certain things and they should have a place to refer their patients. And then how to follow up and multidisciplinary team, it is weight reduction. Doctors say, I don't know where to find a physiotherapist. I don't know where to find a dietitian. We can't coordinate our diaries to have a one meeting. This is what we have heard. We don't have a meeting room, all three of us to meet with the patient. And so these are the real challenges, despite the evidence says that. How do you really capture that is the question. And sometimes you have good interventions, like in France, where the health insurance says if the patient's HbA1c control is good over more than 6 months, and if the doctor has prescribed physical activity as a prescription, they get extra incentive. And then sometimes when we tell doctors what to do, they don't like, right? The health professionals don't like others telling them what to do. And then the resistance comes within the system, not from outside. But if you create an incentive, the system adapts itself. If you say we are giving the general practitioners practice more money, if you control your patient's NCD, they adjust themselves. Then doctor think, okay, I should spend time to prescribe physical activity. Then I don't have time to measure blood pressure. I will ask nurse to measure the blood pressure. If you tell that to doctor, give this task, they don't like to give away that task. The nurse thinks, oh, I have to measure blood pressure now. I don't have time to fill these forms. I might give it to the receptionist. Receptionist thinks I don't have time for this. I'll build it into the application where they book the appointment. We ask, do you take sugary drinks? Do you drink alcohol? The system itself adapts around that incentive to deliver what we need to deliver. So taking the systems approach and introducing the right incentive sometimes get the implemented. But in order to capture that, we need good implementation science. I know your center is focusing on it, so I really want to get into that. This is exactly the kind of information and evidence we cannot get, very difficult to get. And if researchers really understand using the context, why interventions work, don't work, how to facilitate, that is really valuable to improve the implementation of those best buys. And asking the right question at the right way and answering them. Is it acceptable? How are they adapting this intervention? How do they adhere? What is the percentage? What is the coverage? What is the implementation cost? These kind of things are very rare for us for our policies, despite the return on investment or cost effectiveness. So we would really want from countries for these best buys researchers to really capture that so we can help policymakers to make correct discussions. I'm not going to go into these details, but there's reports I put. Just if you go through the slides, you can read some of these reports and look at how we have tried to build capacity to bring researchers and policymakers together so researchers really write the research question in a way to help the gap that policymakers and practitioners have. Now I'll move on to a few other things. We were also talking about nutrition policies. Almost all the countries in Europe have a salt reduction strategy. They will develop a strategy to reduce salt in most common food groups such as bread, cheese, processed meat. But very few countries can evaluate actually. 1 or 2 countries have data to evaluate it, right? That's because they don't have the data from these products, product by product, the salt level over time, what happens. Normally, when governments will announce a salt reduction strategy, sugar reduction strategy, industry say don't regulate us. We will do it voluntary. And then they will show some products, say, look, we reformulated products and show there are few products. But nobody buys those products. They will reformulate few products that no one buys. So if we really want to see whether their reformulation affected the population level salt intake, sugar intake, and intake, we need to have the sales data. We need the sales weighted average, right? How that really changed at the population level. And that's where government needs the composition data and sales data. And a lot of governments don't have that. It's very expensive to buy that from research companies, that data. But we have, about 3-4 countries who use that for their policy monitoring. So this is a huge gap to monitor our nutrition policies at population level. And then next question is, now in many countries, more than 50% of the calorie comes from out-of-home sector, either from supermarket meals or from cafes or from meal delivery apps, etc., which doesn't have any information, right? The portion size or the nutrition information. So if half of your calories come from a section where you have no information, it's very difficult to plan your population level policies. So the challenge we have is how do we get calorie and other information from this out-of-home sector? Cafes, in some countries now they make it mandatory for cafes to show calories, but next level will be salt, sugar levels, at least starting from there. And then do we have new methods to get those numbers? That's where people say that nutrition experts want perfect data always, and they are waiting for years. We still don't have the data. So the people say, we can estimate this using AI. Take a photo. We will tell you how much salt is there, sugar is there. And this is the gap we have. We need an honest conversation. How can we really build the trust about AI data? How we can really improve those models so we get some good data. But waiting for the perfect data for every cafe's cake and food item is also not going to happen. We have learned that over the last few decades, that's not happening. So how can we really use the technology to give us some direction, trustworthy data to take decisions? So use of AI from meal delivery apps and other places to give us some information about nutrition composition is something we are working at the moment. And I know you have some expertise on this area. I thought that might be help to mention. And there are others as well where we can use AI. I'll come to that, especially monitoring of digital marketing. I'll talk about it when I come to that point. Another point is this changing dietary pattern. So we know EPIC studies, like the EPIC Oxford has predominantly a vegetarian cohort. But those vegetarian cohorts, age groups may be slightly different to who we see as young vegetarians today, what they eat. And like in Switzerland and even in Germany, you have detected iodine deficiency in young adults, young girls. And that we don't capture that in these long-term cohort studies in vegetarian cohorts. And then when Switzerland says this is because the young vegetarians or vegans, when they say vegetarian, they eat a processed vegetarian meal from the supermarket. And actually, Germany government did a really good study or consultation with industry to find out what's going on. And they found out actually food industry doesn't use iodized salt in food. because different EU countries have different salt iodization levels. And so if they put the German level, they might not be able to sell it in another EU country. So they thought it's better not to put iodide salt at all. So our salt iodization standard has resulted in completely having zero iodine in the salt, because that's the way to comply with the laws of different countries, different standards. And that's one of the fundamental reasons why we are seeing rising levels of moderate iodine deficiency in Europe, which we thought a problem we solved 100 years ago in Europe, right? And now governments are funding other regions to address iodine deficiency, while we have rising levels of iodine deficiency here. So this is a complex issue. This is not an evidence issue. This is really coordinating different sectors, agriculture, health. And so if countries are really adamant, for my population, this is the right level of salt iodization, they are not going to get any victory, because the industry says EU is one market, we should be able to sell everywhere. If I iodide, I'm not going to sell it. And this is a time to be flexible and practical and really see how we can move forward. But you have some cohort studies, you have maybe different age group. This is the issue we need more. We had a meeting in Brussels. We talked with stakeholders, but this is something we require, and German government's work here is commendable, and they are really working hard and to solve it. But one country can't solve it at the moment. I thought I'll mention a few things about breastfeeding. I think WHO European region is the lowest exclusive breastfeeding in the world. We spend the most money on research to describe the benefits of breastfeeding. So you have the context relevant evidence, but we don't have the impact of the policies, to multiple reasons. One of the reasons, when I ask from my breastfeeding experts, they say we have the lowest threshold to prescribe by health professionals, prescribe formula milk for any simple allergy. We jump on saying start formula milk. And they think that's partly because a lot of training for these health professionals are organized, training materials are sponsored and organized by industry. That's one big issue. And on the other hand, we recently did a survey about breastfeeding indicators. Look like the countries don't have consistent indicators to measure breastfeeding. So when we ask what is the exclusive breastfeeding rates, countries give different numbers measured in completely different ways, completely different numbers. So one thing now, first survey we did about what are the indicators you are using. Report will be coming out soon. And if anyone from the collaborating center is working on this space, I'll be very happy to have your support to review this report, provide some inputs, because as the next step, we will try to harmonize this with countries. Marketing restrictions. So I'm going one by one some of these best buys, okay, cost-effective interventions and about the implementation. Restrictive marketing of unhealthy food. So children is one of those policies we are promoting. And we know it's hard. The UK recently updated their, Portugal has a law, Norway recently adopted a law. So a few countries are taking legislative action. But the most difficult part is monitoring, especially now the marketing happens in the digital space, to monitor whether children, if you ask companies, they say we don't target children. And they will show their social media page and website, there's nothing targeting children here, right? But so if you really want to monitor, you have to look at from children's device. Do they see? Does it come to their device? Then you know about the ethics and how difficult to do that research. I don't need to tell you. But some countries have done these studies. Reports are there. So that's where we have developed some AI tools and applications that could, with consent, install. And then the issue comes, you can't look at children's devices, what they're communicating with their parents. So if there's an AI tool to recognize no human involved, at the device level, identify the products we want, alcohol products, vaping products, unhealthy food products, and only those images goes for analysis. It helps us to collect data and give policymakers the tools to monitor such policy. So we have developed that, but they always require updates. Each country will have their own ways. How to monitor digital marketing is one of the major barriers to implement the policy, right? To describe the issue and also empower policymakers. Don't worry, put the law, you can monitor it. Without a monitoring system, nobody will be rushed to put a law, and it is hard. So this is another area where AI can help for us to monitor children's exposure. Health enhancing physical activity. So this is our report that we do once in 3 years with the European Commission about for each country about their physical activity policies. There are 23 indicators. Indicators are mentioned in the report. What we are seeing is, you can see that about 90% of the countries say we have these policies now, right? That's again comes to the implementation and measuring implementation, what we call the ceiling effect. So we are now revising these physical activity indicators. But these slides are going to be circulated. We wrote few things where we can work with you on improving our physical activity work, including geocoding and technical guides on wearable PA surveillance, right? Everybody still go on asking people how much physical activity you did based on questionnaires, and how can we really get more objective measures with wearable devices, and again at population level to have trustworthy. And then people say, oh, everybody is working with a mobile phone or a wearable watch. But at population level, we are not using this data, right? So data is out there, we are not using it. How can we break these barriers? If the data is out there, how can we get it to policy planning at national level? And these are the things we want to do for physical activity, but also linking it with other sectors such as climate change, urban planning. COSI, again, for you, for Germany, we are very thankful the work you have done in Bremen with Childhood Obesity Surveillance Initiative. We produced the reports. I'm not going to go into details, but with WHO going through a lot of changes, our capacity to work with countries is low. And we would be very happy to work with you on analysis of this data. A lot of countries want to publish their own reports, their own analysis. And we as a WHO on our own struggle to provide that support. So we work with our collaborating centers. So if you want to work on COSI data, support one of the countries to write their reports. We'll be very happy as a collaborating center for you to be there and work on that data and get some publications, but also help our countries to get their data out. But also, Ante and others have been helping us a lot to harmonize some of the indicators to measure physical activity nutrition in these data sets, working with other countries. We improve the protocols. So these are some of the work we are doing. And then we can measure other things, screen time, etc., in a better way as we... And harmonization of NCD questionnaires, risk factors, because different countries measure these things differently. So it's very difficult to compare. And there are reasons why they don't want to change, because they have done it for last 30 years. They want to compare their trends, right? And then how do we keep a balance between allow them to look at their trends versus bringing countries to one indicator to comparability is a scientific challenge, diplomatic challenge. And that's where we need to spend time and have a lot of understanding and patience to do so. So thank you again for your role in that. I saw the poster on your collaboration center poster, the methodological competency platform there when I went to the library on your wall. So this is a piece of work that Ivo and our colleagues really value and your contribution. And we think it's not just science, and it's also require patience and a lot of understanding to work with multiple scientists to do that. So thank you for your support to WHO on that. There are new challenges. I was thinking, what can I mention about new challenges? I thought trade wars, trade policies are very common now. We see how that's impacting on our health. Despite governments introducing prevention policies, often international investment agreements come on their way. So, for example, a government would decide to put a nutrition label or restrict marketing of unhealthy food. Then suddenly, they will see that this is not in line with one of the international trade agreements, investment agreement their government has signed with another government, okay? And the company based in the other country will use their government to notify your country that your public health measure is not in comply with the investment agreement that they signed. That health officials probably had no idea, or they were never consulted, right, in that process. So how can we, as health professionals working on health preventions, whether it is related to nutrition, tobacco, alcohol, really build our partnership with trade experts and really educate them about what kind of population level policy environment you are trying to create, so their trade agreement doesn't become incompatible or clash with your health policies is important. We are learning this a lot. We are also learning that some countries, especially in South America, they carve out public health. They say, look, yes, there's trade agreement, but public health is for the national priority. If it's completed priority, we have right to take the public health priority. They write it into the agreement, but we don't see that much in Europe. Often when there's a dispute, it's go to arbitration board. Arbitration boards are mostly trade people, and their job is to say free trade is the answer for everything. Nothing should come interfere with that, public health or anything, and it goes in favor of trade. So this is a new challenge we are seeing to really promote NCD best buys and NCD policies. And our understanding and our working with multiple stakeholders with trade is important there. And that is why at domestic policy space and commercial environments, working with the lawyers and policymakers, this would be important. We consulted countries to ask, some of these best buy recommendations are more than 10 years old. Why in 10 years have we not been able to implement them? And these are some of the key barriers. So we interviewed policymakers in ministries of health, the civil servants or the public health experts. Some of them is mostly governments think, oh, these are individual level things. People drinking alcohol, people smoking, people not moving enough, eating unhealthy food. We should educate them more. So we put the blame on the individuals. This narrative of this is individual choices is still there. So public health experts, is very difficult to convince politicians that shift this narrative. So this continued narrative is one of the main barriers. And then economic priorities often take the precedence over health. So you might have a very cost-effective intervention, such as putting a warning label on alcohol, that alcohol causes cancer, or a food label. But moment you take it to a cross-governmental meeting, of course, the industry will give your economic ministry data. This is going to cost us something. And that come to the table. Our initial reaction is let's not do anything that has any harm or any impact on the economy. So this is what our government officials say. At the policy-making table, economic priorities often take the precedence. Then the health, they don't reject it, they keep it. And then the parliament expires, and then after next 5 years, you have to start everything again. Right? That's why we never see them being implemented, despite being on the list of recommended priorities. And then intervention that impact industry face significant opposition and low political will. So industry pressure is a major barrier. That's what we identified. That's where we come to commercial determinants of health. We launched this report during the Belgium EU presidency by the Belgian Deputy Prime Minister and Health Minister, Frank van der Broek in Brussels. And that report identified what are the common industry practices interfering and delaying these public health policies. And sometimes it's through scientific practices, like they're funding research by industry to favor their argument. So moment when you write a good summary and a piece of evidence for the government, when the debate start in the parliament, say evidence shows this, they will have somebody else showing one paper saying, no, there's also research showing the opposite. So we need to discuss this again, or we need to commission more evidence. That's how you delay it. That's enough for them. And then manipulating the single market law. If you talk about a label, when you start to health topic, sometimes when you start it at Brussels level, they will lobby and say, oh, no, this should be done at national level. Public health is a national competency. When you start at national level, they say, no, you can't do it alone. This needs to be a EU-wide thing. So wherever policy comes, they use the EU single market law to stop and delay public health policies. So we have documented 35 case studies in our report, such things. So if somebody says in Europe, we have a very good transparent policy-making process that industry interference doesn't happen, you can show that report, real case studies, no, it happens right now here, that our evidence-based policies are not making. What I'm trying to say is when we don't get enough support from policymakers to implement good policies, our normal approach has been, let's produce more evidence. Let's make a really convincing argument so nobody can disagree with us. But we have learned that's really not working, right? They're asking for more evidence. It's a tactic for delay. So if we really understand the power dynamics, how different stakeholders work, we can really prepare for that, strengthen our public health leadership, and align our actors with the voices of patients, families, to really build that voice, not just through evidence, but in a way that with transparency and advocacy. Now, I want to take a few examples. Can it be achieved? I think it can. So in Europe, we have not been able to get a mandatory front of pack label. These are European products. You see them in our market, but that is how it's sold in Argentina. Same product. So these companies, when European governments start discussing public health labeling policy, they come and say, no, if you put a label, company will collapse, we will lose all the jobs, it will be a disaster. But when some governments take the leadership to go and put it, they 100% comply. So my South American counterpart, I'm responsible for European region, my counterpart in PAHO say compliance on front of pack labeling is more than 95%. So it's more than 95% of the product comply with the law, right? And here we think, oh, it will never have worked. It will be a disaster. We would not be able to get it. And this is the same. These products in European markets, our consumers will never see the warning, whether they are high in sugar or salt. But in Chile, there are 12 countries, not one or two. I just picked these two. There are 12 countries in South America who have mandatory labels, and it works. Population get the benefit. The second thing is sometimes we think having the policy is enough. So, for example, these are 4 countries. USA doesn't have a mandatory front of pack label. Other 3 countries have a label. We might think all 3 countries have the same impact, but it's not. In negotiations about what's the cutoff value for the nutrient profile model for salt, Mexico has the strictest salt number. So you see the salt in the same product, same company in Mexico is less than half of what a USA bag would take. But even compared to Peru and Chile, Mexico has done better. So sometimes we have the policy, but industry managed to really change the numbers. So policy doesn't really have an impact. So it's having a policy is one thing, but really details based on evidence is another thing to get the public health benefit. So these are the 2 layers we need to make sure policy, but also the actual numbers to get the benefit. Finally, yes, I want to re-emphasize there are always good news, right? Even in Europe, it's not all bad news. These are 2 good news that I had the pleasure recently to bring to our WHO website from Norway and from Lithuania. From Norway about marketing of unhealthy foods, new legislation, including digital marketing, and Lithuania, new sugar sweetened beverage tax. I know for Germany, this may be interesting. And this include energy drinks as well. I realize now we should have put it on the title. It's not just SSPs, it's also energy drinks tax. So there is momentum, it's happening. And as I mentioned, it's always requires systems approach. So going forward, what we are trying to see is how to understand, not just with evidence and epidemiology and public health, how to leverage that complex system, agriculture, trade, finance, to make the real policies to bring our prevention. And as I said, with the war and conflict, everyone is interested in increasing defense budget, less money for health. Is it really a challenge or can it be a benefit? Are some countries introducing health taxes to raise the budget because they need the revenue? There are always multiple ways of looking at it, but the important thing is for us to have a systems approach, have some system science, and use that system to leverage a system to improve public health and health impact. I'll finish one last example is our behavior and cultural insight teams work on arts and NCDs. How arts I put one systematic review there, and this is our meeting report. How some countries are now prescribing art intervention to prevent NCDs, reducing loneliness. We know it's a big issue in many countries, especially with the elderly population, but also in some countries like with patients' rehabilitations, with after stroke. This was in Hungary when we did the meeting. In some hospitals have choirs for the patients, and that significantly increased patients coming back to the clinic, follow up after the stroke. So hospitals who are running this choir for the rehabilitation has improved their speech therapy significantly, compliance much better, and they are very good evidence. So that's another way of working with other sectors, not just what we traditionally think others. Finally, coming back, I think there are 3 shifts we can think about: redefine our engagement, who are the stakeholders, strengthen our governance to really look at transparency, lobbying, public health registers, who's meeting with whom, etc., and act collectively around public health. And these are some of the work we have done with you, but I really think there are other areas we can expand with your collaboration, with your institution, because we see a lot of potential to work more with BIPS on these to achieve our common goals at national level, but also at European level. Thank you very much.
Very much, Kremlin. This was really a fast ride or